Good afternoon, dental internet world. My name is Dr. Vishal Sharma, once again alongside my friend and colleague, Dr. Mike Parchewski. Mike, it's good to see you. And that really is the best intro for our guest from the University of Utah. I'll let you take it away, say hello, and introduce our esteemed colleague who will be our guest for today.
Hey Vish, good to see you again, and good to be back in the podcast studio. Super excited today. We're entering into VIP territory here. We have Dr. Mark Ludlow, the section head of implants, digital dentistry, and removable prosthodontics at the University of Utah. And he's also a CDOCS and SPEAR resident faculty. He's one of the people that inspires me, and I learn a lot from in the different courses and different conferences that we go to. What I love about him is if you're sitting at a table with him, you would never know that he's one of the preeminent implantologists in the world, as he just will talk to anybody, help anybody, and is super supportive of anybody. There's no arrogance here. Just one of my heroes in dentistry. So I'm super excited to have you with us, Mark. Welcome to the podcast. How has your day been today?
First off, thanks for that intro, man. I mean, geez, like I got to send a check in, I think, for that. That was pretty awesome. So I appreciate it.
Send it in U.S. funds, please, Mark, not in Canadian dollars.
Definitely in U.S. dollars, because I mean, who knows where it's going at this stage. But the day's been it's kind of funny. We were talking before, it's been an implant complication afternoon. I mean, my very last one was drilling out a freaking screw and taking out the implant, abutment, and all this stuff. So it was quite the end of the day, to say the least. So those are never fun when you've got to drill, in this little tiny hole all the way down until the abutment screw's gone. So,
well, we're not going to drill you too much on this podcast, so hopefully it's all downhill from here.
Yeah,
but
it's easy peasy from here.
Easy
forward.
peasy, yeah. So, Mark, obviously you've got a wealth of experience in implantology and specifically complications, which is something we're going to be discussing today. But tell us a little bit about your educational journey in dentistry, kind of what led you to the current position that you're in right now, and how do your current teaching and practice responsibilities, how are they divided?
Sure. So I kind of, I took kind of a different path than I think most. I mean, I actually started as a lab tech in the 90s, and that's where I first started kind of getting into some digital stuff, because back then, all we had was a Nobel Procera scanner, and that thing was freaking awesome. We thought it was so cool that we could build just copings. We're like, dude, look what we can do. And it was just pretty neat to be able to do that. And then it has just progressed and progressed and progressed and progressed. I went from there to dental school at University of Connecticut. Almost went into pros right then, but, decided, dude, I just need to get out. I need to earn some money. I need to live life for a little bit. So I went into practice, was in practice here in Salt Lake for about 6 to 7 years, and ended up selling my practice and going back and doing pros, because I decided to make that decision because the days where I was really happy with, the days I was most stoked to go to the office were the days that, I was doing big full mouth rehabs, big implant cases, different things like that. And the days where I just wasn't that stoked were the days, I'd have like 40 fillings on that day, and it was just freaking brutal. So I decided, what's 3 more years on top of, another 30, 35 years in a career. And so decided to go back to do pros. Finished up pros at UNC, and that was a perfect fit for me, just because our philosophies lined up really well. And then from there, almost went right back into private practice, but decided, I want to try education, just because sometimes, I don't know how your prosthodontic education was, sometimes it's kind of stuck in the 70s. And so I really wanted to try to bring some of the digital components and try to get a lot of that going in pros. So that's why I decided to spend some time in education. And I've been doing that for a lot of years now. And, currently at the University of Utah, I think I'm 4 or 5 years deep here. And it's been good. It's fun. I mean, it's just like any job, I spend about a day and a half seeing my own patients. So it's just, all normal pros and implant related patients. And then the rest of the time I'm teaching classes, I'm teaching on the clinic floor, I'm doing all those things, and we just have a good time.
Nice.
That's fun.
Both of our professors in university, our pros professors, were from the University of North Carolina.
Yeah.
Oh,
Yeah,
yeah.
And
well-known school.
they probably taught everything from the 70s. That might be actually a little bit generous. Maybe some of it was from 1968, but both
I
great
mean, you get
guys.
some plaster from Home Depot, start mixing that up, and I mean, it's mucostatic. It's awesome.
Yeah, perfect. It's all what we need. Yeah.
Yeah.
And you can sculpt things, Vish always likes to do a little sculpting, kind of, artistic side of him comes out.
It's good therapy.
It is, yeah. Mark, we were talking a little bit, obviously, about your day today, dealing with complication, and I think it's pretty cool that you're doing a lot of education and training now for dentists on managing complications. Tell us about the course that you've created for CDocs and what what the dentist is learning in that program.
Oh, sure. So I'll be honest, this one's kind of been a passion project of mine for years, because I mean, it's very rarely, back in the day, it used to be very rarely a day would go by, but it's very rarely, 2-3 days go by where I'm not having to dig something out, whether that's a broken screw, broken abutment, a stripped screw, you name it. That's usually what ends up in my chair. And it happens all the time in implant dentistry. I mean, if it hasn't happened to you, it's gonna, everyone that's listening to this, it's gonna happen to you. And the unfortunate thing is there's really no good way to learn it and learn how to manage these complications. And so for years I've been kind of racking my brain of how to simulate screw ups so that then we can figure out how to fix things. And I finally came up with a pretty good idea, and then we've worked the concept up, and it's going to be pretty awesome, because I tried to figure every single possible thing that happens, and then from there it's just a matter of creating a model that simulates all of that, anywhere from just simply a loose screw retained crown to a stripped screw to a broken abutment to a broken tie base to a fractured implant, you name it. We've got a simulation to be able to do that. So I'm pretty excited about it. It should be pretty fun.
Sounds like an
Fun
innovative
in a very
course.
Demented sort of way.
My methodology is just texting Mike in a panic, and then if he doesn't respond within 2 minutes, I just power call the office until someone picks up the phone. So
I just keep dialing and dialing.
That's right. Free daytime calling with my cell phone plan. Do they still have those Mike cell phone plans? I'm going to pivot back, Mark, to something you mentioned before, and that was you were drawn towards education because you wanted to bring more of a current methodology to prosthodontics. So is that kind of one of the things that drew you towards working with some Sirona or Dentsply Sirona products?
Yeah. I mean, the interesting thing is I got my first scanner. I got a RedCam back in 06. RedCam, and back then all there was the compact unit. I mean, you remember those days? I mean, I was so stoked when I bought something called the Powdermeister. I mean, I literally got it because I thought the name was awesome.
Yeah, I had the RedCam as well.
Did you?
Classic, yeah.
You remember going from RedCam to BlueCam? You're like, holy crap, this is like a huge change. It was just like exponential growth. And, it's always been stuff that's interested me. And, I've really focused a lot as well with DS implants because I placed 22 different brands of implants in my career. And, originally I kind of thought screws were just kind of screws. And, to some extent, I put some of the cheapest ones in just because to try to make our margins and all these different things. And the reality is, watching these progress over time, I came to realize that really there are a lot of differences in the screws, and the bone response is different in them all. And so to me, that's why I really gravitated to DS implants, with Astra and whatnot, because it just held bone, unlike most any other implant. And so, coupling the digital with the implant side, that's kind of how I progressed here and gotten with DS, with CDocs and the like, because it lines up with what I believe and what I do.
Yeah, I think, taking it one step further, for me, through that ecosystem, when I was using the, BlueCam into OmniCam, is we started getting into how do we do this guided. And, this is back in the 2000s, and, we were doing, suck down impressions and drilling holes and looking
at the drill press, remember?
Yeah. Oh, yeah.
You're like, I got a drill press.
Yeah, it was pretty cool back then. And, that has really emerged, and I find that dentists are getting into it now. It's a huge difference. And so, walk me through, when you're educating the dentists, how much you feel that the guided process using things like Simplant. How is that making a difference from your eyes in seeing this through education for dentists to get into implant dentistry and also be more successful with their implant placement?
Yeah, I think it's kind of interesting how you bring that up because it really does help you be better. Okay. Like I have so many of my colleagues be like, well, I don't need guided. I know how to place. And I say, well, me too. When we started, there was no guided, there were no CBCTs, were no any of these things. And, we all cut our teeth, if you will, free-handed. But I think what guided does is it allows you to bring in all the other elements of treatment planning and bring it together so that you, in the heat of the moment, don't have to make some of these decisions. And you know exactly where it's going to go. You planned it exactly according to biologic and prosthodontic principles to where you can get the best results. And so the way that we kind of educate people and we kind of work people up is everything starts with the intraoral scan. I almost call that the gateway drug to digital. So we scan every single person that comes in. And this is not only my practice, but what we do with students, residents, everybody. So everybody gets a scan and then everybody gets a digital wax up or a digital design, because the reality is the days of just placing it where the bone are, I think those have died a number of years ago, and we're all doing it prosthetically planned and placed. So once we know where that tooth needs to be, from there's a variety of different rules that we will follow to be able to get the implant into the proper spot to house that tooth. So we go from the digital wax up to planning the implant to then creating the surgical guide, whether we're doing it and printing it ourselves, whether we're milling it, whether we're outsourcing it. Again, the process is pretty similar for all of those things. So again, and the manufacturing method, again, we could talk about that forever. But the reality is, again, usually we're printing these or getting them built for us from a printing facility.
Yeah,
And then
printing has
there,
changed a lot, hey?
Oh, it's crazy.
Yeah.
Like it is
so
absolutely bananas. But then the ability to place the implant, place a pre-made temp, all those different things. I mean, it just simplifies your life and kind of takes the pucker factor out of doing some of these cases, to where we used to be stressed, or you'd put the implant in and like that was the easy part, and then you'd spend forever doing the pros part. Well, you've got a pre-made custom abutment, you've got the pre-made crown. It just all comes together like Legos, and man, it just makes your life a lot easier clinically.
And are you teaching these for the general dentist students as well, Mark? Like, are they going through a lot of these digital workflows, or is it just it's more limited?
No, every single solitary implant case that comes in goes through that. I mean, that was what I initiated, like literally day 2, was every case needs to be waxed, every case needs to be scanned, every case needs to be planned, because they need to understand all the principles that are involved. And it's not just all of us that do this that see you get a better result, but that's what the data parses out too, is like guided can be, at least from a positional perspective, kind of a great equalizer amongst the rookie all the way to the experienced. Is it brings those a lot closer than anything that we've had previously.
And Mike and I have discussed that on numerous occasions, where it is, the great equalizer, especially for more simplistic implant placements. It becomes, truly that, just a bit more simplistic for a GP even getting into it. But let's talk about some things that are not simplistic. I'm excited for this upcoming course on complications. It's going to save Mike a lot of text messages at the end of the day. But
that's why I developed it, is just so you'd stop texting.
Exactly. Thank you so much.
So what is your favorite complication to deal with? And the follow-up question on that is, what's your least favorite? Like, what gets you back to when you're a GP and you had a day full of fillings and you just look at the schedule and like, oh, I'm not looking forward to this. So your favorite complication, most predictable, that is just something you can hit out of the park every time, and then your least favorite that just makes the hairs in the back of your neck stand up.
Probably most favorite are the easy ones. I mean, and again, I had one Tuesday, stripped healing abutment. Everyone freaks out. Well, I can't get it out. That literally will take you 5 seconds to get that sucker out with the right tools. And so we could just use like a reverse torque tool, which is basically a tool that as you turn it counterclockwise, the thread pitch goes deeper and deeper and deeper. It grabs, and then we can twist it out. And like, it was funny because we had one, like I say, 2 days, no, yesterday, I guess. And again, it was in and out in about 5-10 seconds. Same deal with kind of broken screws that aren't just super torqued in. Those as well, with some of the right tools, we can generally get those out pretty quick. So those again, the easier it is, those are my more favorite ones because you don't have to go through you know the valley of doom to get there, right? My least favorite is what I just did, like I say, an hour ago, when you've got an absolutely beyond torqued screw. You've got an abutment that is in it. This was in an ankylose. So ankylose have very, very deep Morse taper, and like everything's cold welded. So that one I had to literally drill the screw all the way down and out, and then use an implant removal tool to grab onto the abutment and then shimmy that sucker out. So that's the worst when you're drilling out a screw out of the middle of the implant, because there's just not a lot of room for air, and like a little slip and you've dinged up the implant. So those are the hardest ones that I do. And luckily those aren't ones that come in, day out, day in, day out. So
Has all of this implant complications, has it led you to have a woodworking shop in your garage where you've got all these tools and that's how you decompress?
So the funny thing about that is, like, I do a lot of mountain biking. I freaking stripped a screw on my bike, and I was so pissed. I'm like, you flipping idiot. You deal with this every day. So like I go into Home Depot and I'm like, I don't know what you guys call it, but this is what I'm looking for. And they're like, oh yeah, it's right over here. So go over and it cost me like $3 or $4 to get one of the reverse torque tools. And I'm like, shiz, man, I wish we could repurpose this for dentistry versus paying like $50. Use the same bloody tool for $3 to $4 from Home Depot. But yeah, I mean, it makes it, when my kids strip out like a Phillips screw or something at home, it makes it a whole lot easier to be able to navigate these issues.
Yeah, and I would echo the cold fusion. That's the one that gets me. Sometimes you'll get a tie base or something that has been in there over torqued, and then dentist calls and says, hey, can I send this patient over? I can't get the abutment loose, and it leads to some fun times. On that front, just a quick question for everybody out there. A cold, like, you can get the screw out. Let's say you're left with a cold welded abutment. What are your kind of key tips to get that abutment loose?
Yeah, so it somewhat depends. There's a couple tools that are really good for it. So first one that I go with is Nobel actually makes an abutment removal tool that's kind of a nifty little tool. And what that does, and again, it doesn't only need to work with Nobel. You can use it with a couple different brands. But basically what it does is it's got a part that you put down into the implant and get it below the end of the abutment itself. And then you put this kind of plunger needle piece in the center of it. And as you squeeze those two parts together, it extends some wings out the bottom. And so once that does, a lot of times just doing that will pop the abutment out. If not, now you've got the wings down underneath, and so you can grab that and wiggle it out.
Okay.
So
Yeah.
that's one way. The second way is, again, what I did on this one today is, again, use a reverse torque tool, an implant removal tool, put that down, twist it, counterclockwise till it grabs. And when it grabs really tightly, you don't want to keep twisting, because if you keep twisting, you'll further wedge the abutment in, and sometimes you can pull the whole implant out. So you twist it just enough till it grabs, and then same deal with that. Just sit there and wiggle, 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 wiggle till you get it out. The
Yeah.
final way, which I've had to do a number of times, and these are the worst, is then you've got to, if you just can't get it to go, if you've got the screw out or cut the screw out, then you've got to cut up the walls and then collapse it in on itself. And those are the worst, because there's a good chance, like, that's where, like, it's when it's titanium on titanium, it's the hardest. Sometimes you get those with zirconia going all the way down, and those are the best because you can see exactly where you're cutting. But titanium on titanium, like, you've got to be very careful and cut like one wall up, cut the other wall up, and then collapse the two pieces and pull them out. And that's the worst.
There's a
Really, really.
fourth way. I don't want to undermine your expertise, but you can send a referral to mludlow at complications at
Yeah.
gmail.com. And
At
just send your,
yourlifesucks.com. Yeah,
yeah,
exactly.
send your patients down to Salt Lake City, quick little flight on Delta, and that's it.
That's
nice,
it.
nice
Easy.
and easy. I wanted to point out one thing. One of my nephews is doing his PhD in physics in Cambridge, and I was actually talking to him about cold fusion, and he was really disappointed when he figured out that I was just talking about a tooth. He was just like, very
Hey,
anticlimactic.
Salt Lake cold fusion, man. That was like 1984 or
It's
something
huge.
where they're
It was
like,
going to
"We created
revolutionize.
cold fusion here."
Yeah.
So, yeah.
Yeah.
But
Going to
yeah,
power
those-
the world.
Yep.
through implant, through cold welds, powering the world.
If you can control the implant health of America, you can control America. So, yeah.
So, Mark, another area that you work a lot with is full arch, right? And as the 3D world and the digital scanning world takes on full arch, that's sort of the pinnacle, right? Like aesthetics and all the planning. So, what currently are you doing, in your workflow, in the workflow to incorporate, digital technology into planning these big arch cases?
Yeah. So for those cases, it's kind of funny. We use the exact same, so much of it's diagnostic, right? Like that's where the rubber meets the road. And that's where I see so many problems is like people just didn't notice really where the teeth went. And so I think it doesn't matter if it's like a full mouth rehab case on teeth, a denture case, or a full arch implant case. Bottom line is we've got to be able to diagnose and figure out exactly where the teeth need to go, and then you work your way backwards from there. So any tools that can help us with that, I think helps us with all of them. So what we generally do is, again, all these patients get scanned. If they don't have a denture and they come in completely edentulous, honestly, I'm making them a denture right out of the gate because I got to know where we're going with the case. So again, incorporate intraoral scanners, CBCTs, implant planning software, again, same deal, printers, all those different things. Because again, the workflows are very similar that you do for full arches as single tooth. Lately, I've had this on and off again thing with facial scanners. Like I got them and then I hated them, and then I got into them again, hated them, and now I'm back onto them again. And we're going to run a study to where, especially with dentures, is we're going to see if it actually makes a difference to have a facial scan. Because I think a really good photo a lot of the times can help you almost as much as blowing, an extra 30 grand on a facial scan. So, but again, that, once we get the data, then I can kind of speak more to whether it's worth it or not. But been doing a lot of facial scans on patients as well, and I usually do three. I'll do one with them lip at rest, so we know where the lip at rest is, because that's where I begin all my cases, a smile, and then a retracted smile. And again, being able to merge all three of those files on top of your intraoral scan really can give you some nice extraoral landmarks, so you can make sure you're not canted, you've got the right, incisal edge position, the right occlusal plane, everything like that. So those are kind of the main things. And then it's just guided surgery and general surgery. So
Yeah,
take it from there.
Facially generated treatment planning at Spear actually does a really good job of explaining exactly what you just talked about, how you set up those cases, whether it's going to be full arch or full mouth or denture related. So certainly worth for our listeners checking out that course if you have the opportunity as well. Speaking of, Mark, where can our listeners go to learn more about your courses and see you in action using some of these techniques you've discussed, whether it's implant complications or an aesthetic printing workflow or full arch implants, which I know you're big into as well, and do some seminars with Spear and CDocs. Where's the next opportunity for us to see you speak?
So again, where we run our workshops through is through CDocs. So again, just cruise on over to cdocs.com and can go ahead and look everything up there. Same deal with Spear, just Spear Education, and you can go from that perspective. Then again, I'm at different conferences throughout, the US and throughout the world. So it just kind of depends where you're at. But again, where we run all the hands-on stuff is through CDoc and Spear. And so that's where I'd come, because that's where, again, like that introduction, where I think it's really fun with people is you get your hands-on experience, but man, you get so much and learn so much just from hanging out at lunch. Like you're just hanging out, eating some tacos, like talking dentistry. I mean, that's like, that part is, I think, the most awesome part of going to a lot of seminars, is because then you can get off on random topics and just speak about whatever. So again, those are the two main places where we do like all of our hands-on stuff. So, and it's really fun. Just come hang out, let's eat tacos and churros together and go from there. So,
well, Mike and I have been talking about doing an event up here in Banff or Lake Louise. So the tacos are terrible up here, but
the scenery is awesome. So yeah,
it is. And for mountain biking Moab Mark, you can bring your bike up here and we'll hit some good rocky trails. So
yeah, that would be awesome.
Mark,
so
I
wanted to go up there forever.
We will.
Let's set it up.
We'll get you a visa and we'll get it set up. We've been talking about doing something actually with CDocs next year. So Mark, listen, that was fantastic. Wealth of knowledge and a lot of fun having you on. We really appreciate it. And we're looking forward to seeing in person. I might not make the next implant complication seminar, but certainly it's going to be in my calendar for this year for sure.
Yeah, super good. Appreciate it.
Sounds good, guys. Well, thank you all very much for having me. I really appreciate it. It's been fun.
Yeah, I appreciate it. And we look forward to meeting you at the next lunch where we can chat more. And Mark, I'll probably see you. Are you going to be at the Piers this year in the summer?
I think so. I've got 2 events one right before, one right after, so I'm not sure. I've just got to see kids' schedule and see if I can make it. But
well, if you're there, I'll stalk you at breakfast, and we'll learn more. I got a complication. I'll come up.
Churros and complication with Dr. Mark Ludlow. There it is.
Yeah, there it is.
I think we're creating a new course, right?
We got it. I do like churros. Well, thank you very much, Mark. Very much appreciated. This was fantastic. Everybody out there, please like and subscribe at Digital Workflow Dentistry, all the podcast channels to find us, Digital Workflow Dentistry. Thank you so much, Vish. Take it easy, everybody.